Welcome to the Cardiology Medicine Boards ABIM review. When a patient presents for the initial evaluation of chest pain without current symptoms, the first step is an exercise EKG. In cases with pacemakers or LBBB, pharmacological radionuclide imaging is recommended, given it vasodilates without affecting heart rate. If a patient has high-risk features on stress tests, even with normal radionuclide perfusion imaging, should prompt further coronary angiography to check for multivessel coronary artery disease. Chest pain on exertion not relieved by nitrates may indicate nitrate tolerance. Reducing nitrate frequency can help. Ranolazine is effective for chronic stable angina by decreasing myocardial oxygen consumption, especially when initial treatments fail. In STEMI, fibrinolytics are contraindicated in patients with recent ischemic stroke, major head trauma, intracranial hemorrhage, malformation, bleeding risk, or suspected aortic dissection. Distinguishing right ventricular myocardial infarction from pericardial effusion post-angioplasty is crucial. Both present with hypotension with jugular venous distension. In RVMI after PCI, classic STEMI in 2, 3, and AVF, symptom improvement with fluids are key indicators, with clear lungs being a differentiator. Whereas Weill-Sommer's pericardial effusion, you'll have pulsus paradoxus, muffled heart sound, and it worsens with fluid. After stent placement, dual antiplatelet therapy should continue for 6 to 12 months. Elective procedures should be delayed until DAPT is completed to prevent complications. If 12 months passed for elective procedure, continue aspirin but hold clopidogrel for 5 days before procedure. In the first week post-MI, complications like pericarditis can happen. In inferior RCA MIs, papillary muscle rupture can present with acute mitral regurgitation, which presents with hypotension, pulmonary edema, and systolic murmur. In LAD-MI, interventricular septal rupture can occur, which presents with new harsh holosystolic murmur, or in LAD anterior MI, free wall rupture can happen as well. Weeks after an MI, patients may develop complications like left ventricular aneurysm, which presents with persistent ST elevation, or Dressler syndrome, which is autoimmune pericarditis, presents with fever, pleuritic chest pain and treated with NSAIDs, or thromboembolism from LV mural thrombus, requiring ongoing monitoring and management. Post-PCI, retroperitoneal bleed is a potential complication, presenting with low blood pressure and tachycardia with flat neck veins. A CT scan of abdomen and pelvis without contrast is the next step for diagnosis. Even after fibrinolytic therapy for STEMI, patients should be transferred to a PCI center. Pseudoaneurysm is a possible complication post-PCI, presenting as a pulsatile mass with a systolic bruit. Anginal symptoms that occur at night may indicate sleep apnea, which can induce nocturnal NSVT. Polysomnography is recommended for diagnosis. High-dose statins are recommended for LDL levels over 190, but they can increase glucose levels and risk for diabetes along with thiazides. Verapamil can heighten the risk of statin-induced myopathy. For cocaine-induced chest pain, treatment includes aspirin, nitroglycerin, and Ativan, but beta blockers should be avoided due to the risk of excess alpha-1 activity. Do coronary angiogram regardless if cocaine or not, given cocaine constriction can lead to clot if ST elevation present. Atrial flutter is primarily treated with radiofrequency ablation. Multifocal atrial tachycardia is ectopic atrial photsy driven by acute issue. It presents with atrial rate of than 100 with 3 different P-wave morphologies with irregular RR intervals. It can be caused by pulmonary disease, and treatment may include bronchodilators and corticosteroids. Direct oral anticoagulants are preferred over warfarin for most atrial fibrillation patients, except in cases of renal failure or valvular heart disease, where warfarin is used. Atrial fibrillation is classified as valvular or non-valvular, with warfarin recommended for severe mitral stenosis and direct oral anticoagulants for other patients. Warfarin INR goals is 2.5 to 3.5 for mitral valve replacement or aortic valve replacement with risk factors. Treatment for atrial fibrillation includes flecainide or propafenone usually. In CHF-LVH, amiodarone is used. With CAD, obviously we use beta blockers like sotalol and radiofrequency ablation for refractory cases. For atrial fibrillation lasting over 48 hours, a transesophageal echocardiogram is needed before cardioversion to check for thrombus. Ideally, patient should receive 3 weeks of anticoagulation before cardioversion. Tachycardia-induced cardiomyopathy can occur with prolonged rapid heart rates. Treatment focuses on heart rate control, often leading to significant recovery of ventricular function. Brugada syndrome is a genetic disorder affecting sodium channels, predominantly seen in elderly males. It is characterized by a typical EKG showing slight ST elevation, greater than 2 mm in the right precordial leads, along with T-wave inversion and right bundle branch block. Treatment is controversial for asymptomatic patients, but an ICD is recommended for those with syncope due to the high risk of sudden cardiac death. Wolff-Parkinson-White syndrome involves an accessory pathway known as the bundle of Kent, leading to a quick upstroke of the PR interval before the QRS complex, known as the delta wave. Stratification with an exercise test or procainamide test is crucial to estimate the risk of sudden cardiac death. If tests are normal, treatment may not be necessary. However, beta blockers should not be used, and ablation or antiarrhythmic treatment is advised if symptoms are present. Congenital long QT syndrome requires the use of beta blockers to prevent arrhythmias, even if the patient is asymptomatic. Additionally, the absence of P waves on an EKG could indicate hyperkalemia, which is often accompanied by a prolonged QRS complex. Cardiovascular implantable electronic devices may need to be removed if there is valve or lead vegetation detected on a transesophageal echocardiogram, positive blood cultures with high-risk organisms, or a pocket infection characterized by pain, erythema, swelling, drainage, or skin erosion. Infective endocarditis is diagnosed using the modified Duke criteria, which includes major criteria like positive blood cultures and evidence of endocardial involvement, and minor criteria such as predisposing heart conditions, fever, vascular phenomena, and immunologic phenomena. It can be associated with low complement levels, positive rheumatoid factor, and can present with splenomegaly. Roth spots are retinal hemorrhages with pale or white centers caused by immune complex deposition and microvascular occlusion. Osler's nodes are painful erythematous nodules located on the pulp of fingers and toes. They are a classic immunologic phenomenon associated with infective endocarditis. Janeway lesions are non-painful, erythematous, blanching macules found on the palms and soles. They are a vascular phenomenon associated with infective endocarditis. Common organisms causing infective endocarditis include Staphylococcus aureus, Streptococcus viridans, and Enterococcus for native valves, and Staphylococcus epidermidis for prosthetic valves. Staph aureus in IV drug users. Empiric IV antibiotics are started after cultures, usually ceftriaxone plus vancomycin. If prosthetic valve, then we use vancomycin plus gentamicin plus rifampin, typically lasting 4 to 6 weeks. Surgical intervention for infective endocarditis is indicated in cases of acute heart failure due to valve issues, conduction failure, recurrent emboli, persistent bacteremia, or complications with prosthetic valves. The presence of a paravalvular abscess, indicated by a first-degree heart block, is also a reason for surgery. Prophylaxis with amoxicillin is recommended before certain procedures, including dental and respiratory tract for patients with congenital heart disease, valvular heart disease, prosthetic valves, or a history of infective endocarditis. It is not needed for other procedures. Rheumatic fever is caused by Group A Streptococcus pharyngitis and is an autoimmune sequela due to molecular mimicry. Diagnosis is based on the revised Jones criteria, which includes evidence of preceding or current GAS infection, including elevated anti-streptolysin O and anti-DNase B titers. The Jones criteria for diagnosing rheumatic fever include migratory polyarthritis affecting large joints, carditis, can involve valves, especially mitral, subcutaneous nodules, erythema marginatum, and sydenum chorea. These criteria help identify the systemic impact of the disease. Erythema marginatum is a serpiginous, annular rash that appears on the trunk and proximal limbs, often associated with rheumatic fever. Treatment for rheumatic fever includes antibiotics, single dose of IM penicillin G, or 10 days of oral penicillin for Group A streptococcus, anti-inflammatory medications for arthritis and carditis, and supportive care for chorea. Severe cases of carditis may require steroids. Prophylaxis duration for rheumatic fever depends on the presence of carditis and valve disease, without carditis for 5 years or till 21 years of age. For carditis without valve disease, 10 years or until 21 years, and in patient with carditis with valve disease ranging from 10 years to lifelong. Benzathine penicillin G is administered every 4 weeks as a standard preventive measure. Atrial septal defect, ASD, involves left-to-right shunting, causing right ventricular enlargement and a characteristic systolic murmur with fixed splitting at P site. The EKG may show right axis deviation and right bundle branch block. Ventricular septal defects are often associated with a thrill and are best heard at the third or fourth intercostal space, presenting as a hollow systolic murmur at the left sternal border. Understanding heart murmurs can be made easy with Dirty Medicine video, which provides detailed insights into different murmurs. Aortic is on right second intercostal space. PTM on led-E. Pulmonic in second intercostal space. Tricuspid in fourth intercostal space. And mitral in fifth intercostal. Let's begin by exploring the world of systolic murmurs, which include aortic stenosis, pulmonic stenosis, tricuspid regurgitation, and mitral regurgitation. Now let's shift our focus to diastolic murmurs, which include aortic regurgitation, pulmonic regurgitation, tricuspid stenosis, and mitral stenosis. Inspiration tends to make right-sided murmurs louder, while expiration amplifies left-sided murmurs. Preload plays a crucial role in the intensity of heart murmurs. Increasing preload, through actions like squatting or leg raising, generally makes murmurs louder, except in cases of hypertrophic cardiomyopathy and mitral valve prolapse. Conversely, the Valsalva maneuver, or abrupt standing, decreases preload, softening most murmurs except HOCM and MVP. An increased afterload, like increased hand grip, makes regurgitant murmurs louder, but softens those associated with hypertrophic cardiomyopathy and mitral valve prolapse. While decreased afterload like with amyl nitrite causes HOCM and MVP to be louder. Aortic stenosis is a condition often seen in older patients, characterized by symptoms like syncope, angina, and dyspnea. The calcified valve can lead to a delayed aortic valve closure, causing a paradoxical S2 sound. They radiate to carotids. No role of beta blockers in treatment. Management includes regular monitoring with echo. Patients with 4 MA2 area or 40 mm Hg pressure need 6 to 12 monthly echoes, whereas half of that 1-ish area and 20 pressure needs 3 to 5 yearly echoes. Mitral regurgitation is often holosystolic and can be linked to a history of rheumatic fever. The murmur typically radiates to the axilla, and it's crucial to recognize these signs early for effective management. The phrase mitral can help you remember its association with rheumatic fever. Surgery in mitral regurgitation should be remembered as symptomatic Mr. in his 30s to 60s need surgery. So, MR surgery recommended if patient is symptomatic or ejection fraction is between 30 to 60%. Asymptomatic patients with an LVEF greater than 60% should be monitored with serial echocardiography every 6 months. Tricuspid regurgitation is another holosystolic murmur, often associated with a history of intravenous drug abuse. The catchy phrase, "want to try some drugs?" can help you remember this connection. Mitral stenosis is diastolic murmur characterized by an opening snap and is often linked to a history of rheumatic fever. In severe cases, it can lead to functional tricuspid regurgitation, allowing both murmurs to be heard. In cases of severe mitral stenosis, percutaneous mitral balloon valvotomy may be necessary. Mnemonic miss needs a new valve if less area, which causes symptoms or pressure. So, indicated when the valve area is less than 1.5 cm, with either symptoms of dyspnea and orthopnea or pulmonary artery pressure of TR 50 part. Contraindication can be remembered as, Miss doesn't need to buy purse herself if she is with her MR, or if her current purse is complex, calcified, or has precious stones. Contraindications include concomitant moderate to severe mitral regurgitation, or complex valve anatomy, or extensive calcification, or left atrial thrombus. Mitral valve prolapse to win MVP, your team needs to click. It is often identified by a mid-systolic click and is common in young women with a psychiatric history. The condition is associated with myxomatous valve disease, surgery for chronic severe aortic regurgitation by SEE-AR Raymond on 5550. It is considered when certain criteria are met. such as an ejection fraction below 55% or a left ventricular end systolic dimension over 50 mm. In rest, regular echocardiographic monitoring every 6 to 12 months is essential for managing this condition effectively. Hypertrophic cardiomyopathy presents with a crescendo-decrescendo murmur best heard at the mid-left sternal border. Differentiating hypertrophic cardiomyopathy from an athlete's heart is crucial. While athletes may have left ventricular hypertrophy, HOCM is characterized by septal hypertrophy and left atrial dilation. Recognizing these differences is essential for accurate diagnosis and management. Hypertrophic cardiomyopathy management includes avoiding high-intensity sports and using beta blockers or non-dihydropyridine calcium channel blockers for symptomatic relief. In refractory cases, surgical or alcohol septal ablation may be necessary. An ICD is recommended if life-threatening risk with family history of sudden death or sudden cardiac arrest history or syncope episode or hypotension, while exercise or NSVT episode or extreme LVH 3 cm maximum septal thickening. A continuous murmur in left infraclavicular area, often described as machinery-like, is a hallmark of patent ductus arteriosus. It usually presents as wide bounding pulses with wide pulse pressure. This condition involves a persistent fetal vessel connecting the pulmonary artery to the aorta, leading to complications like left heart volume overload and pulmonary hypertension. Also, Eisenmenger syndrome with R to L shunt and infective endocarditis of PDA. For patients on warfarin with valvular disease, certain procedures pose a low bleeding risk. These include outpatient dental surgery, cataract surgery, and minor outpatient procedures. It's important to continue warfarin therapy during these interventions to minimize thrombotic risk. In high-risk bleeding situations, such as those involving mechanical valves or recent venous thromboembolism within last 3 months, heparin bridging is often required. For moderate-risk cases, like bileaflet aortic valve patients or CHADS VASC of 4, heparin bridging might not be needed. Infiltrative cardiomyopathy can be caused by conditions like amyloidosis and sarcoidosis, leading to increased left ventricular mass and thickening. This condition may be misdiagnosed as left ventricular hypertrophy, but low QRS voltage on an EKG can help differentiate it from other causes like hypertension. Acute viral pericarditis is best managed with NSAIDs and colchicine. It's crucial to avoid using steroids in acute cases, reserving them only for refractory pericarditis. The progression of EKG changes in pericarditis can be observed through 4 distinct stages. Initially, there's an upward ST segment elevation, followed by normalization of ST and PR segments. Diffuse T-wave inversions occur next. And finally, either normalization or persistence of T-wave inversions is seen. Constrictive pericarditis is characterized by increased jugular venous distension, a pericardial knock, and Kusamal's sign, which is JVP increase with inspiration, is also noted. This condition often presents with right-sided heart failure, where pulmonary edema may be absent. Cardiac tamponade is marked by the collapse of the right atrial diastole, given the low pressure in the right atrium. Clinical features include a water bottle heart on ultrasound, pulsus paradoxus, which is 10 mm drop in BP on inspiration, and elevated jugular venous pressure with rapid X descent with muffled heart sounds and hypotension is part of Beck's triad. Peripartum cardiomyopathy is a condition with risk factors such as advanced maternal age and multiple gestations. It presents with a decline in heart function to less than 45 in patient over 36 weeks of gestation or within 5 months of delivery and requires standard HFrEF treatment. Patients should be advised to avoid future pregnancies. For patients with blood pressure greater than 140/90 at 20 weeks of gestation, antihypertensive medications like labetalol can be beneficial in preventing preeclampsia. Heart failure with preserved ejection fraction, HFpEF, we use diuretics, spironolactone and Jardiance with exercise training. There is no role of beta blockers in HFpEF, whereas in reduced ejection fraction, HFrEF, require tailored GDMT with ARNI/SLA beta blocker, and diuretics followed by introduction of spironolactone, followed by Jardiance. In heart failure with reduced ejection fraction, HFrEF, supplementary agents like hydralazine, isosorbide nitrates, especially in blacks and digoxin in persistent cases, can be used to manage symptoms and reduce hospitalization, although they do not improve mortality. CRT is indication if left ventricle ejection fraction less than 30% or less than 35 with prolonged QRS or symptoms. BNP and NT-proBNP levels are crucial in diagnosing heart failure. False higher levels present in older individuals and those with chronic kidney disease, whereas false lower in obese people. Dry cough can be caused by both ACE inhibitors and ARNIs. ACE inhibitor can alleviate calcium channel blocker-induced peripheral edema. Milrinone increases inotropy, improving contraction, alleviating dyspnea, and reducing CHF symptoms. Digoxin toxicity initially presents with gastroenteritis, kidney injury, hyperkalemia, and cardiac arrhythmias, later progressing to neurological and visual symptoms. This ain't stroke, commonly confused. Diagnosis by symptoms, not by lab. Management involves IV fluids and digoxin-specific antibody fragments. Even if hyperkalemia, no calcium gluconate as digoxin inhibited sodium-potassium ATPase already.